Orthopedic problem during the pregnancy is not uncommon. We all know that there is now one child norm, so each and every baby is important. Each and every pregnancy is high risk pregnancy. Why? Because maximum women are used to do work outside, and for our hectic lifestyle they used to have baby after the age of 26 or later 30. So each and every problem should be addressed properly. And most encountered problem in orthopedic during pregnancy is trauma, pregnancy related pelvic girdle pain, carpal tunnel syndrome, plantar fasciitis, transient osteoporosis, and tumor flare up have a chance also. All the pregnant women need to wear an seat belt very properly, because sometimes many of the women don't want to wear them to prevent any hurt or any injury to the fetus. But if they wear the seat belt properly as shown in this picture, there will be less chance of the acceleration injury or acceleration injury or direct injury to the fetus. One step under the uterus and one step above the uterus in between the two breasts. This is the ideal position, and this position must not accepted in between at the umbilical line. That will cause more harm to the fetus. And the most maternal death are due to head trauma and hemorrhage, shock. But fetal death usually due to maternal death or due to placenta abruptio. Placenta abruptio is also associated with preterm labor, rupture membrane, uterine rupture, and direct fetal injury also occur during this seat belt injury or any type of blunt injury. Not only seat belt, there is a chance of blunt trauma of the abdomen also, along with spine injury. So there is a chance of amniotic fluid embolism also. Now, along with the management of fracture or spine fracture or any type of injury after this trauma, we first take the importance to the fetal heart rate monitoring. For this is the most worrisome problem of this blunt trauma abdomen is abruptio placentae, and it can be easily monitored with the new gadgets for monitoring the fetal activity externally. And we must follow the mother up to 4 hours. This is the protocol. And this high risk, all the pregnancy are predisposed to DIC or ARDS because of abruptio placentae, dead fetus, shock, sepsis, and amniotic fluid embolism. And there is a chance of DVT because all during pregnancy it is a hypercoagulability stage, and after any type of trauma we have to manage that lady with a 30-degree tilting the bed to prevent the aortocaval compression, which also help in the long run. And always we keep the mother with moist oxygen, which will help to continue the fetal circulation properly. And regarding the long bone fractures or any type of fracture, we all know that fracture has if fracture can be managed conservatively, that will be the best solution for each and every pregnant mother. Until and unless it become open fracture, we easily can go for conservative management. Even for thigh bone fracture also we can use Thomas splint. And there is a rule of 10. If we want to take any x-ray, you should post that x-ray in the first 10 days of the menstrual cycle, because in that period the conception is unlikely to be occur, and the diagnostic radiology in pregnancy should be done for only a critical condition, and there we can use a shield to the uterus as much as possible, and we must consult the radiologist for a minimum exposure, and exposure less than 5 rad is not associated with increased fetal anomaly or any pregnancy loss. You have to counsel the family member, because sometimes they can blame you that for X-ray there is the problem with the child, but the problem with the child or mother most commonly occur by due to trauma. Now again another topic is transient osteoporosis of during the pregnancy. This transient osteoporosis most commonly occur in the third trimester, with that will predispose the pain on activity and reduce after rest. And the X-ray will show the osteopenia, and MRI will show diffuse bone edema, and there is a typical double line sign seen in the head of the femur, and bilateral hip can be affected for this type of problem. It can evolve into transient migratory osteoporosis, means there is a pain over the hip, there is a pain over the knee, there is a pain over the wrist. It's called transient migratory osteoporosis, and treatment is conservative only, and it will decrease if the patient will decrease weight bearing, and it will settle down within months. But the diagnosis and assurance to the patient and family member is most important. Now another important topic is pregnancy related low back pain and pelvic girdle pain, and how we will manage. The most common dictum or most common proposal hypothesis of this type of problem is round ligament strain, as during pregnancy the uterus become heavy, and the whole weight bearing and axis center of gravity is shifted anteriorly. As a result, there will be low back pain associated with the pelvic girdle pain. The pain is experienced between the posterior iliac spine, crest, and the gluteal fold, particularly in the area of sacroiliac joint. The pain may radiate in the posterior of the thigh and can also occur in conjunction and or with separately in the symphysis pubis also. The endurance capacity for standing, walking, and sitting will be diminished. But the diagnosis of a pelvic girdle pain must be excluded from the lumbar disease like spondylolisthesis or any type of spinal problem. And we don't know actually what is the real cause of pelvic girdle pain. Maximum is uncertain and all are multifactorial. But some author says that it is due to effect of relaxin and progesterone. But treatment is bed rest and pelvic tilt exercise, acupuncture. Sometimes we can give paracetamol, and if the pain is intractable, we can give over the posterior superior spine. We can use the depometrol with local anesthesia under CM coverage, or we can do it by our hand estimation. Lastly, there is some nerve compression problem and some tendonitis like carpal tunnel syndrome. This syndrome characteristic by pain and tingling sensation over the second, third, fourth finger. It can affect both hands, and most commonly it aggravate at night. Is also called nocturnal acropathica, most commonly associated with the pregnancy or diabetes or hypothyroidism. And then the cause of this entrapment syndrome or carpal tunnel syndrome is the compression of the medial nerve in this transverse carpal ligament. Sometimes it needs operative management, but before that you have to exclude mm, all the differential diagnosis of this entrapment syndrome. And if we have a history of pregnancy, we can go for night splintage only. That will help, and counseling of family member properly regarding this the compression of the nerve, and it will subside automatically. And another problem is plantar fasciitis. Plantar fasciitis itself is a very irritating problem for working women, and it generally not subsided by conservative management easily, and it may needs steroid injection along with local anesthesia. But after this injection also, patient can complain repeatedly with the pain over just insertion of the plantar fascia just below the calcaneum. Some authors suggest the X-ray, and there is a calcaneum spar, but it has no radiological or clinical correlation with this plantar fasciitis. And the cause of plantar fasciitis, how and why it is exaggerated in pregnancy, we do not know. But only foot massage is very helpful, or acupuncture is very helpful, or passive stretching is very helpful during the pregnancy period. If pain is not subsided, then we can go for local steroid injection with local anesthesia. But passive stretching and foot bath is very helpful for the plantar fasciitis. And rheumatoid arthritis pain during pregnancy will exaggerate because the immune system get prepared of the body to nature of the developing fetus, and joint swelling and pain usually improve during the second trimester of pregnancy. But sometimes 20% of the women have severe worsening of rheumatoid arthritis syndrome during the pregnancy. But at that time, the time of the pregnancy, we should not add the DMRD, because that DMRD can cause teratogenic effect to the fetus. So we have to manage them by paracetamol or physiotherapy and local heat and infrared therapy. There are many type of physiotherapy like ultrasound therapy, infrared therapy, and all can manage the pain. And you have to go for proper counseling of that patient, and we can start DMRT after the delivery. And some women is also suffer from lupus erythematosus or SLE, and along with the all problem of SLE like skin, heart, kidney, mental problem, lung problem, blood immune system, and mouth problem, there are 30% of the SLE patient may develop joint and muscle problem like swelling of the joint and SLE-related arthropathy. This SLE-related arthropathy may be exaggerated during the pregnancy, and the management again is conservative only. No need to go for steroid until unless this is totally indicated. And sometimes if we go for steroid, you have to take consultation of the medicine department. And along with this we need a close observation of SLE patient, because they have a chance of recurrent abortion along with fetal heart block if a patient is suffering from SLE. And last but not the least, some tumor like fibrous dysplasia has a receptor for estrogen and progesterone, And as pregnancy is a hyper estrogenic state, progesterone is increased, so the flaring up of hypoxia may occur in the pregnancy, so there is chance of pathological fracture may occur, but no treatment is required except the splintage, and operation should be avoided during the pregnancy. And there is some oral tumor can be flare up like Epulis. Thank you.